And Kelvin, you're good to go.
Thank you. And thank you, CCSN, for the opportunity to allow me to present to you and the group about real-world evidence in general, and also to introduce the CanREValue Collaboration. So for today, I will first start with going through some background information about real-world evidence. I suspect that a lot of you will have heard a lot about real-world evidence in the past little while. And each time I find that when I go to a talk about real-world evidence, I always find that there's something extra or different. So hopefully we'll be able to give you something a little bit different today. And then I'll go into some case examples of real-world evidence evaluation in Canada and in Ontario. And at the end, I will then introduce the CanREValue Collaboration, which is the Canadian Real-World Evidence for Value of Cancer Drugs Collaboration. So with that, I shall start with what is real-world evidence. There are many definitions about real-world evidence, or RWE, as you can imagine, and a lot of you may have come into contact with various definitions. So here I cited an FDA, the US FDA definition. And naturally, we start with the data first, and so we call it real-world data, RWD. And real-world data are the data related to patient health status and or delivery of healthcare routinely collected from from various sources. So that's how FDA defined it. And so some examples of RWD include cancer registries data, hospital records, and insurance claims. And not uncommonly, for those jurisdictions that have the ability to link different databases, often they would try to link up different databases, including cancer registries and hospital records and insurance claims, to come up with a bigger data set, which allow for analysis. And with that, then we generate evidence from the data set. So with the application of statistics and different methods, and with the focus of specific questions, then we generate the real-world evidence, RWE. So with that, it's usually defined as real-world evidence. It's a clinical evidence regarding the usage and potential benefits and risk of a medical product derived from analysis of RWD. Again, this is from FDA. So now, how do we use RWE, or what would be the potential usefulness for it? In terms of thinking about patient-centered care, thinking about access to drugs, often we hear about the term, the triple aim, appropriateness of prescribing, accessibility, and affordability. And RWE potentially can play a role in some of those aspects. So just some examples include in areas where the disease is very rare, often people will find that it is exceedingly difficult to conduct randomized controlled trials. And often the best available evidence would be non-randomized clinical trial data, and sometimes the sample size can be small. And so there's this notion that maybe if we can also include real-world evidence in jurisdictions where the drug is available, then those can supplement the clinical trial non-randomized data to allow us to have a better understanding of patients' experience and their outcomes with those drugs, which may potentially help decision makers or regulators to make decisions. And in addition, after the drug is approved, then in those cases, it may also help post-marketing surveillance and look at whether after funding the drug or after the drug is available in the jurisdiction, whether the performance of the drug, whether patient's experience match up to expectation. Another example could be thinking about appropriateness of prescribing. Sometimes randomized controlled trial will capture a specific group of patients because of their eligibility criteria, and sometimes those criteria were there not necessarily because they believe that that's the best group that patient will benefit, but often is to increase the chance that the trial will be successful or positive, and so they have some restrictions. So one common eligibility criteria is performance status, and some of you may have heard of the ECOG performance status score or scale, and often a lot of randomized controlled trial will have the criteria of 0 to 1 as their criteria. And often it's debated that maybe patients with performance status 2, sometimes they may still be doing quite well and may benefit from the drug, even though we may not have direct evidence from randomized controlled trial. And in Canada, PCODR recently has often made recommendations instead of saying restricting to patients with ECOG 0 to 1, they may say patients with good performance status can be considered for this drug. And sometimes the question is there a way to confirm that patients who have performance status 2 who will still be benefiting from the drug and not being harmed from the drug. And those information cannot be gathered directly from the randomized control trial that has excluded patients with performance status 2. And so that can be another example where real-world evidence potentially can help us understand how patients do in the real world and assess for appropriateness of prescribing. And also, in terms of affordability, I think we can all appreciate that, especially for jurisdictions where patients may have to pay out of pocket, sometimes outside of Canada in some other countries, for example, people, if the drug is very expensive and it's not affordable by patients, so clearly it would be a problem for access as well. And there's this notion that if the cost of development of the drug it's not as high, and in cases where real-world evidence can be helping to advance the development of the drug, and I think some of the manufacturers may also hope that if there's sophisticated method that real-world evidence can be as good as RCT, maybe it can even lower the development of the cost of the development of the drug. Whether that reduction in the cost of the development of the drug will pass over to patients in terms of lower price, I guess that's also something that it's not as clear, but certainly it's a possibility. And after a drug is funded, the other possibility is that we can use real-world evidence to look at real-world value for money, real-world cost effectiveness. And if the drug is priced in such a way that in the real world it's not cost effective, unlike the original projection, then maybe there's opportunity to renegotiate the price. And in that case, maybe then we can free up the budget from a payer's perspective and allow for more access for future drugs. So there are a lot of theoretical potential opportunities for the use of real-world evidence. Now, thinking about affordability and sustainability, I think we can all appreciate that if we are not able to afford cancer drugs moving into the future, then we actually will create a problem with access. So affordability and access actually are related concepts and not just independent concepts. So on this slide, this is an Ontario related slide, but you can see that over a span from 2011-12 to 2017-18, in that 6-7 years, we see the total cancer drug budget to have really skyrocketed, more than doubled. So the annual growth rate is more than 11%. We know that Canada's economy is not growing at that pace, and that simply suggests that if this trend continues, Canada just cannot afford to continue to pay, and therefore in the future there may be challenges with access if this continues. The next slide here shows the same picture, but in addition to that, we can see that earlier in 2011-12, the distribution between intravenous drugs versus take-home cancer drugs, they're about 50-50%. But now fast forward to more recent times, we can see the oral take-home drugs, the budget is actually increasing even further. And partly because there are actually more drugs available, especially take-home drugs, which is more convenient for patients, which is a great thing. But partly also because that not only that we have more drugs, but actually individually the drugs are substantially more expensive, which is a potential challenge. So in 2015 in Ontario, the Cancer Quality Council of Ontario conducted a programmatic review on the topic of drug funding sustainability and tried to look to international experts and national experts to give recommendations about how to have a sustainable, healthy drug funding system, because we hope to be able to continue to maintain good care and good access to useful drugs to patients. So they made 7 recommendations, and out of the 7 recommendations, 2 of them related to real-world evidence. So the first one there is that there's a call for a consistent approach to gather and to analyze real-world evidence. And this should include systematically capturing and incorporating patient-reported outcomes such as quality of life or side effects into real-world data collection. And in addition, there's another recommendation that real-world evidence should be used to inform and monitor effects of drug funding decisions. Now, in addition to that, I think most of us will be familiar with PCODR, CADAS. It is a health technology assessment group in Canada, maybe with the exception of Quebec, that will give recommendations about whether a drug should be funded or not, and specifically for PCODR, it will be cancer drugs. INES, which is based at Quebec, performs similar functions in Quebec. And for the first 60 drugs reviewed by PCODR, CADAS, up to a total of 21 reviews actually have make reference to request real-world evidence. 13 of those were more explicit, and 10 of those were kind of more implicit and potential. Of note, they don't add up to 21; they add up to 23 because some reviews actually both have explicit and also some implicit reference to real-world evidence. So there's a call for collection of data. The challenge is who should be in position to be answering them in a systematic and consistent way. We do appreciate that sporadically there will be different groups, either academic groups or patient groups or groups from other jurisdictions or from manufacturers who actually may be in a good position to answer that call from PCODR. But it would be nice to have some systematic way to deal with the call. So moving on, what are the potential outcomes that may be relevant for many different stakeholders in terms of real-world evidence? I think in the space of cancer, naturally, people will be interested in real-world survival. We want to know how our patients do in the real world, how long they live, and in addition, whether they do well on these cancer drugs, whether they have side effects that's manageable or side effects that's challenging to manage that leads them into hospitalization or even potentially fatal side effects from those drugs. There will be obviously important reasons to want to know about how our patients do with their quality of life on these treatments. So survival is only part of the equation, but quality of life is very important. From a payer's perspective, people may be interested to know about utilization of health services. It may potentially help planning for the future and also understand about the economic impact of the treatment. And if we put all those things together, we probably will be able to come up with some real-world estimation about the cost effectiveness of the drug. So I think from that discussion, we can naturally appreciate that multiple stakeholders may have use for real-world evidence. So patients may be able to understand those different outcomes better so that they have a sense about, as a group, how they do, or even individually, how they do if they have access to the data. So effectiveness, safety, side effects, quality of life, and especially patients who are in a situation where they are not represented on the randomized control trial, then sometimes people wonder whether they still benefit or whether they're going to do better or worse. Other stakeholders, clinicians, myself and my colleague naturally will find that while it's good to look at randomized control trial, but we know that we have to treat real-world patients, and real-world patients may not look the same as patients on the clinical trial because of the highly selected nature of who can get onto clinical trials. And so we naturally will want to learn more about what happened to our patients and how to manage our patients in the real world rather than just from the randomized control trial data. Payer and decision makers understandably will have an interest as well because they naturally will want to know with the investment they make with the aim to improve the health of the population. Is it doing what it's supposed to do? And increasingly with the investment they're making, they naturally will want to know whether the investment is bringing incremental benefits to the population. And industry also have many reasons that they may want to know about real-world evidence. Sometimes if they are thinking about the pre-market space, understandably, that may be an opportunity for them to gain access to the market to have their drug funded or even funded earlier than otherwise. And post-marketing data may also be helpful to them for many different reasons, one of which can be to plan for future studies for next generations of drugs. So now moving on with all those background information, I want to share 3 examples to illustrate how population-based real-world evidence may potentially help or inform decision-making or inform the different stakeholders about the current scenario. So the first example, it's called Azacitidine. And this is a drug that is funded in Ontario in 2010. It's for the treatment of a condition called myelodysplastic syndromes, and I will call it MDS, as well as acute myeloid leukemia, AML. Those are very serious condition, understandably, and there are not a lot of treatment options for these diseases, especially back in 2010. And when azacitidine became available, there was a randomized controlled trial showing improvement in overall survival, showing that people live longer because of this drug in those particular indications. And at the time, it was felt that it's important to fund it, but there's a challenge about funding this drug because the schedule of how this drug is given intravenously, and it's given on 7 days in a row, consecutively 7 days. So that means that if we start on a Monday, it will continue into the weekends, Saturdays and Sundays. And we can, I think, appreciate how challenging it can be in terms of creating a healthcare system that will allow for access of 7 days in a row intravenous injections through the ambulatory outpatient chemo unit. Almost none of the chemo units in cancer centers will be open 7 days a week. There are some centers that may open on Saturday as well, but not on Sundays. And if the alternative is to admit patients as an inpatient to deliver those 2 doses on the inpatient unit, it also can create trouble in terms of occupancy for inpatient hospital beds. And we have all heard about hallway patients' concerns, issues because of inadequate beds. So it may just create more problems for other people or patients who are also potentially waiting for a bed on the cancer floor. So it becomes a challenge. At the time in 2010, the thought was through expert opinion for those experts who understand how the drug works. There were 2 other alternative proposals. One proposal was to think about funding the drug 6 days instead of 7 days. For those experts who understand the pharmacology of this drug, they think that maybe 6 doses each time will provide a similar benefit. But obviously, on paper, it seems like a 1/7 dose reduction every cycle, and so naturally can make people nervous about that approach, especially when there was no randomized control trial data to show that they're the same. Another approach that the experts recommended was to do 5 days first, Monday to Friday, skip the weekends, and come back to do the remaining doses on Monday and Tuesday. And so that's sometimes called 5-2-2 approach. And seems like the total dose will be the same. I guess the question there is the overall intensity of the treatment is altered because it's taking 2 days longer to complete the same total amount of doses, and so the intensity of the dose seems to be less. And whether that will have an impact or not, it's not as clear. Experts felt that it probably will be okay, but again, there's really no direct data. So at the time, the idea was in order to allow patients to have access, based on expert opinion, let's go for all 3 regimens being allowed and then collect data, including some of the important data that we usually don't have at baseline, such as specific patient characteristics about their genetic makeup in respect to MDS and AML, as well as other baseline characteristics. And let's collect those as well as how people do over time, how long people live, and then see what happens. And so this slide actually, it seemed a bit busy. This is a survival graph, and each of the curve represent one of the 3 different treatments. And if one of the treatments is better than the other 2, you'll see that that particular curve will be to the right and on top of the other 2 curves. But in this particular case, you can see that those three curves are kind of superimposed on each other. And for those who actually can see in the middle, the word that says p-value, that's the statistical test to look at whether those treatments are different or the same. And this p-value is quite big. So big p-value usually means that those three curves are not really different statistically from each other. So that seemed to suggest that all three regimens, the way we give the treatments, they are pretty much the same. That really provide a lot of reassurance that the original intent to encourage, to enable access, to allow those three regimens, the strategy worked out, and we have the data to show that. This analysis was conducted by one of my colleagues at Sunnybrook, Dr. Rena Buckstein, who is an expert in MDS, and this has been published by her in one of the journals. So, in fact, with the findings, we actually were able to review the data and the analysis with a group called the Ontario Steering Committee to Cancer Drugs, which is an Ontario specific health technology assessment committee. And they have clinicians and health economists and pharmacists and also patient representation as well. And when there's some cancer drug related issues that require deliberation and possibly voting, often it will come to this committee. And so they had the opportunity to actually review this particular real world evidence analysis. And were able to deliberate and say whether they feel the three regimens are pretty much similar and whether funding for all three regimens should continue. And at the end, they deliberated and agreed that the evidence is sufficient to allow permanent funding of all three regimens of azacitidine to move forward. So that was an interesting example to show life cycle assessment, meaning that there was some idea, a notion to collect data prospectively before the drug is funded, and then collect the data while the drug is funded with three different regimens, and then afterwards actually analyze the data and actually reassess and to see whether the initial decision that was made was the correct one, and to look for opportunities to potentially change that if the data didn't really borne out that way. Now, moving on to another example. So this is, we call it Pancreatic-ESAS Study. So ESAS stands for the Edmonton Symptom Assessment Score, and it is a score that includes many different patient symptoms while they have cancer and or receive treatment. Some of those will be physical symptoms, some of those will be psychological symptoms. And in Ontario, in regional cancer centers, there's a platform called ISAC that has been established since 2007, and now the name has changed. It's called Your Symptoms Matter. So essentially, different regional cancer centers will have kiosk or sometimes paper survey to ask patients on a routine basis and sometimes on a longitudinal basis how their symptoms are based on ESAS scores. So after patient reported their symptoms, those symptoms actually will be shared with the clinician, and so the clinicians will have real-time ability to look at the scores and even look back at their previous scores and see if those symptoms changed over time. So that was the original intent of this platform from Cancer Care Ontario and the regional cancer centers. But naturally, that created opportunity to collect data about patient symptoms and their experience over a period of time. And therefore, if we take advantage of the availability of that data set, and if we combine that data set with other data sets that will give us information about patients' use of drugs, for example, and how well they do in terms of how long they live, for example, then we can actually be able to kind of map out the entire experience of patients of how their symptom changes over time, and also look at the effect of drug on their symptoms. So one of the studies that we do was that we were hoping to look at whether the symptoms of patients at the time when they were first diagnosed or when they first received before they received the drug, whether that is related or is associated with how long they live. So whether symptoms relates to survival. And in this case, again, this is survival curves. The blue line here patients with relatively less symptoms, so lower symptom burden, and the red line here represent patients who have more symptom burden, higher symptom burden at the time when they first started treatment. And we're able to follow all patients who have contributed data to this data platform over time. And you can see the two curves, that the blue curve is on top and to the right of the red curve. And you can also see that the p-value on the top right-hand corner, which is a small p-value, less than 0.0001, which shows that patients with less symptoms in the beginning, even before they receive treatment, they have a better prognosis. They live longer compared to patients with more symptoms. So that's kind of an example to show that we can actually use patient symptoms as a way to contribute to population-based data sets to come up with analysis. And so some of the lessons we learned here, we are definitely seeing an increasing use of patient-reported outcomes. So ESAS is one of the patient-reported outcomes over time, and the ability to do that on almost like a population-based fashion. We can also appreciate that now from this study, the baseline symptom of patients for pancreatic cancer, anyway, it's associated with how long people live. And that may seem to suggest that it would be potentially interesting to extend the study to beyond the real-world evidence database RAM, but to more like an interventional RAM. How about aggressively managing symptoms early on when patients first diagnosed? And for patients who start off with high symptom burden, if we aggressively manage the symptoms so that they have less symptom burden early on, could that actually make people live longer, independent of just the cancer drugs? Like, can symptom management actually improve survival? So that seems like real-world evidence can help generate further hypotheses, and those hypotheses can be looked at either through further real-world evidence study or even through more proper clinical trials or other designs of study. Now, another example I want to share with you, and this is the last example I want to share with you at this point, is a study that was conducted in 3 provinces. And in Canada, we have multiple provinces, and many of us have heard about the fact that some of the provinces, actually a lot of the provinces, have pretty good data, especially in the cancer space. And often are population-based, so that they are unselected, and we have everyone's experience that we can try to collect and summarize. But there have not been a lot of concerted effort to try to coordinate and collaborate to do studies across multiple provinces, mostly because it's actually not easy to coordinate, but also that a lot of the data reside within the province, and the data cannot leave the province for analysis. Now, in our study here, the 3-province study, the data still could not leave the province. It's still within each of the 3 provinces, but this is one way to illustrate that it's possible to try to do an analysis using comparable data elements and comparable design and comparable analytic plan to come up with results, and then see whether the results are comparable or not. So in this specific situation, we are looking at the use of bevacizumab in metastatic colorectal cancer, and to see whether the randomized control trial that showed benefit of bevacizumab in this setting, whether they translate into the real world with similar benefits. And so we were able to establish a group of patients who receive bevacizumab with chemotherapy in the first-line setting, as well as a group of patients whom we call them control patients because they receive chemotherapy but without bevacizumab. And that may be because they were from a timeline where bevacizumab hasn't been funded yet, or maybe they are from a timeline that is after bevacizumab is funded, but for various reasons, they have not been getting bevacizumab. And by doing the comparison of patients who received bevacizumab with those who did not, we were able to do a comparative analysis for 3 provinces. So that was it was done in Ontario, BC, and Saskatchewan. And we were looking at the budget impact overall. We're looking at safety from a patient's perspective. We're looking at effectiveness in terms of survival and also cost effectiveness. So the result of this study will likely become more publicly available. It will likely be presented at CABIS in April, so we'll have more information at that point. So far, the analysis went well, and so it's kind of a proof of concept that multi-province analysis is possible. And so far, it seems like there's evidence of clinical benefit, and there's no strong safety signal concerns, which are encouraging. And the result across provinces in this specific example seems rather consistent province to province, which may not always be the case in all types of cancer drugs. So in this specific case, it seems to be consistent. And also there were opportunities for the analytic group to learn more about different methods, statistical methods approach to try to assess how robust the result is, recognizing that real-world evidence data, they are not randomized data. So because there's no randomization, there's no perfect way of ensuring that patients who receive bevacizumab are otherwise identical to patients who did not receive bevacizumab in any other way except the receipt of drug. And therefore, a lot of different methods and statistical analysis had to be in place, and there has to be some ways to assess for the robustness of the findings based on different scenarios. So that's a good opportunity for the analytic team to learn or to explore all those different methods. So those are the 3 examples I want to share with you to give you a flavor about what real-world evidence from population-based analysis can do, which may be a little bit different than other real-world evidence case studies that you may have heard from other scenarios and examples. Now, then moving on to the CanREValue Collaboration. So the purpose of people coming together and thinking about real-world evidence is because it seems like if everyone's doing different things, then we may have challenge trying to put everything else together in a thoughtful and cogent way to allow clinicians, patients, or decision makers to assess real-world evidence and how should we use it, or how do we make decisions from it. So the goal, the overall purpose of the CanREValue Collaboration is to develop a framework for Canadian provinces to generate and use real-world evidence in a consistent and integrated manner. And the hope is that it will provide information to many different stakeholders, but for people who make decisions, hopefully it would help with the future state of reassessing cancer drugs after it's funded, and to see whether there's any signals to confirm whether a drug works in the real world as well, whether there's any safety signals or not, whether there are some groups that's not well represented in the original clinical trials that we have more signal, more data on, and so that we know whether patients benefit more or less, or being harmed more or less from the drug. And in addition, in the real world, people will be able to assess real world cost effectiveness. So if the initial price projected by the initial clinical trial data felt at the time was reasonable, but subsequently found to be overpriced, then there may be opportunity to reassess that and see if a better price can be renegotiated to free up the budget, so that future drugs may be able to access the market because there's more room in the budget. So currently we're working with different individuals from many different organizations and stakeholder groups, including the Canadian Association of Provincial Cancer Agencies, the provincial cancer agencies themselves, health technology assessment organizations, including CADF, PCODR, and INES, provincial ministries of health, PCPA, and to some of you may know that that's a group that helps with pan-Canadian negotiation with manufacturers, patient and family members, CPAC, which is the Canadian Partnership Against Cancer, applied researchers, Health Canada, and PMPRB. So this is a multi-year project initiated and funded by CIHR. And right now it's a 4-year multi-year multi-stakeholders project the plan is to start off with an environmental scan to understand the landscape of RWE both in Canada as well as other jurisdictions, and also to conduct a qualitative interview study to understand the different perspectives um, of the stakeholders, especially in Canada, and then develop different working groups with the view to develop the different aspects of the framework and hopefully then piece them together to have a more organized and continuous framework. And once we have that, then we will hope to be able then to conduct population-based real-world analysis in multiple provinces, similar to what we just described about the Avastin project, but with a different drug, but following the draft framework, um, and hopefully do it in more provinces, and then see what lessons we can learn from it. So the goal is not as much as what exactly um, the drug is doing in the real world, even though we will learn a lot about the drug from a clinical standpoint, from patient standpoint, but also importantly, if we conduct a multi-province analysis by applying the draft framework that we come up with from the working groups, then we can learn about the lessons, the strengths and limitations of the draft framework, and so we can revise the framework um, further. And with the revised framework, then we can conduct another multi-province real-world analysis. And from the second analysis, we'll have more lessons learned, and then use that to refine the framework one more time. And hopefully, at that point, everyone, all the stakeholders, everyone involved in the process will have multiple opportunities to look at the strengths and limitations of the framework and can help revise it so that hopefully it can be considered for further usage in the future. So far, what we have done is we've conducted an environmental scan, we've conducted a qualitative study, and we have established the working groups, and all the groups are working hard to come up with their aspect of the framework. So in terms of the environmental scan, I won't go into too much detail with this one. It was previously presented as a poster in the Canadian Centre for Applied Research in Cancer Control annual conference last year. But just to share with you that the scope of that review was quite broad, including international scope and both cancer and non-cancer real-world studies, looking at observational data through almost a 10-year time span. And there are many messages, but some of the high-level messages is that there are really many different data sources for real-world data, and many different types of design in real-world evidence. And some of those we will want to bring into the framework. And also, definitely many descriptions of how the various stakeholders may benefit from the use of real-world evidence or real-world data throughout the life cycle of a drug. And in terms of the qualitative interview, this component was led by Dr. Yvonne Bombard on behalf of the study group, and they conducted multi-stakeholders qualitative interviews. Each of the interviews lasts for about close to an hour, and it's semi-structured and include multiple stakeholders. The findings of this study will be presented at CADAS this year in April in Edmonton as an oral presentation. So for those who will be going to CADAS, I think that it may be interesting to look at what Yvonne and her team has to say about the findings. I won't want to steal her thunder, but I would just on a high level suggest that there are 4 themes that she'll be focusing on, including the perspective of the respondents about the current state of the data, the call for a paradigm shift if we want to move towards RWE, the need for capacity building, and also the need for collaboration among all stakeholders. So I'll leave it for her and her team to share with us in April about the details of the finding. Now moving on in terms of working groups, understanding that the framework can be quite broad, and we are focusing mostly on the space where a drug is being considered for funding into, and then looking at post-funding collection of data, and then looking at possible future state of reassessment. So we have established 5 working groups, including the planning and drug selection working group, the data working group, the methods working group, the uptake and reassessment working group, and the stakeholder engagement working group. So if I think about the sequence chronologically, not that there's any particular order to each part, but just for convenience, first we probably want to think about how to plan and select for real world evidence project, drug indication projects. So the focus of this group is to develop recommendations to establish provincial infrastructure for real-world evidence, and also to establish some criteria, if you will, about how to select a drug or a project for RWE using provincial population-based data sets in a systematic way. And Scott Gavura from Cancer Care Ontario is leading this group. And the focus of this group is to look at how should drugs be selected for evaluation, what criteria should we be thinking about in terms of selecting or prioritizing which drug should be considered, what evidence is required for decision makers if we were to do a project, and what are the infrastructure and resources needed to do it. So understandably, there will be a lot of grounds to cover for this one, and the approach is a modified Delphi approach of members from many different stakeholders and different organizations. So moving on, the methods working group naturally focus on recommending methods to analyze real-world data to minimize bias or to enhance methodological rigor. And this group is led by Dr. Jeffrey Hodge from UC Davis. And the main goals of this group is to come up with many different questions, but importantly, what are the main outcomes or main measures that we should be considering? What are the interesting questions that people want to know about real-world evidence that will help with decision making? Again, because this is a methods group, naturally it want to ask the question, what would be the appropriate methods for the different types of outcomes or measures? And every time when we measure something, we also have to quantify the degree of certainty or uncertainty. And so we need some ways to describe the amount of uncertainty coming from the real-world evidence, and also looking at the uncertainty of the data itself. And also, once we have the results from different provinces, how do we pull them across provinces? Are we making decisions individually within provinces, or more in line with current thinking? How do we make decisions more consistently across provinces as a country? So moving on to the data working group, this is a working group that help identify strategies to help access data across provinces, and also to try to harmonize data elements so that when we are comparing studies across different provinces, we are ideally looking at comparing apples and apples and not apples and oranges. And Dr. Claire de Oliveira, who is a health economist from CAMH, is in charge of this group. And some of the questions that they will be tackling include what are the database available in which province, and what data elements available, and also the practical issues about accessing those data, how to access them, and how long it would take. Now, the next working group is the Uptake and Reassessment Working Group, led by Alex Chambers, who many of you know is the director of PCODR CADIS. And the main goal of this working group is to develop strategies for the implementation of the findings of RWE from a HTA reassessment perspective and from a policymaking perspective. And so important questions that they're going to tackle include how to initiate a reassessment. Currently, we do not have a established reassessment process with CADIS PCODR, but with the interest to develop a life cycle reassessment strategy for health technology assessment purposes, or sometimes we call it health technology management purposes, because now we're looking at lifetime management instead of a one-time assessment. This will be an important working group to help guide the future. So who should be conducting reassessment? What are the enablers and barriers to conduct reassessment, and possibly refining original funding decisions? How might reassessment be different from initial assessments? So there are many questions that this group will be trying to tackle. And again, this group will be adopting like a modified Delphi method, and we'll have multiple meetings, including teleconference and in-person meeting, as well as surveys to help address each of those questions. Last but not least, Dr. Bill Evans, a medical oncologist from McMaster University, will be leading the engagement working group to ensure appropriate input from all key stakeholders were obtained in all the steps with the framework development. And Bill will love to be able to present here today as well, but because of some last-minute unforeseen circumstances, he was unable to present today, and so he sent his regrets. But he has been involved with the development of this presentation and was really looking forward as well to discussing real-world evidence with the participants of this webinar, but also with in the future with different patients and patient groups. So some of the topics that this group will be looking at is how do we effectively engage payers, clinicians, industries, patients, and patient groups so that we can get all the nice input and feedback to improve the framework further iteratively over time. And so one of the questions that Bill really want to ask, or at least want to share with the group and see if people have some thought, is that number one, naturally, he'll be interested to know whether patient groups or different patient groups have an interest in engaging with the CanREValue Collaboration. And I guess the simple thing to do is, if the answer is yes, then please email using that email address to indicate your interest, because I think Bill will love to hear from people and to find out who may be interested in participating with the future development of the framework. And another set of questions that Bill would like to ask, once we know who will be interested to participate in the engagement, is what would be the most optimal way to allow us to share and exchange information and to seek input from patient groups. One idea is that maybe each patient groups can share their thoughts and response once we have some early draft recommendations, so that we'll be able to use their feedback to revise the framework accordingly. And we also naturally have to think about logistical issues. Certainly, we may not have the capability to manage hundreds of separate emails and feedback, so some way of coordinating will be very useful. So one potential idea is to have information or feedback collated within the respective patient groups, and then have the patient groups representing the thoughts and opinions within the patient population, and then we can exchange information that way. That's one way, but certainly we are open to further discussion, and so we'd definitely love to hear from you about your thoughts, and also feel free to email us with that email address. So with that, this is the last slide here. Just want to share with you that we are at the midpoint of the second year, and so we are about to be developing the first draft recommendation. Hopefully that would be somewhat ready enough that it will give people a flavor, but definitely by no means finalized or complete, because we will need the input from everyone to help revise it so that it will be useful and relevant for the different stakeholders group. And once we have that, later on this year, we will then start to be planning to do the multi-province real-world analysis, hoping to be able to then test out the framework and see how it performs. So with that, this is the end of my presentation, and thank you for your time and your attention, and I would really appreciate if you have any questions for me. Thank you.
Thanks, Kelvin. So we have a couple of questions coming in, and just a reminder to everybody that if you have a question, now is the time. You can type your question into the box in the GoToWebinar panel on the right side of your screen on your computer. So I'm just going to address these questions in order, Kelvin. I think you can see them as well. The first one we got is, what is the process for removal of drugs from formulary as new and better drugs become funded?
Okay. If I understand correctly, did you say removing a drug from the formulary when better drugs becomes available?
Correct.
Right. So I think that depending on who you talk to, some people may describe that as disinvestment or reinvestment because essentially, I think the idea behind it is if some of the older drugs that's not as useful or some of the older drugs uh, that is that may actually have more side effects comparing to newer drugs. Maybe by removing them from the formulary, then it may make budget room for newer drugs. Um, so certainly, this investment is a potential outcome as drug comes through the pipeline. And now, when we say older drugs, it really depends on what we mean by older drugs as well, because I think we may all appreciate that the price difference between drugs in 2019 versus drug that has been around and has been genericized, there may be a bit of a gap there. So I think the long and the short is that I think all those options are something that we're actively exploring. And if we have to think about prioritizing which project to do first, because you can imagine we won't be able to do 100 projects simultaneously in the future if there's enough resources and if there's actually if we will start to see benefits for all the stakeholders of this approach, there may be more resources and more established system over time. Initially, we may have to start off with a few projects to see how it works. And therefore, we may need to prioritize projects that will give the biggest bang for the buck, so to speak. And if the older drugs actually are expensive, pricey older drugs that is not very valuable, then those would be good opportunities to look at because that may be a way to allow for entry for other drugs. But if those are older drugs that are very inexpensive, then that may not be as worthwhile to be the first few cases that we do because it may not lead to a lot of obvious tangible benefits. I hope that answered that question.
Yeah, thank you. The next question here is interesting. In the context of real-world evidence, how do you define real-world?
I think that's a really, really good question. Pretty much the most loose definition is pretty much anything that is not within the clinical trial space is real world. But I think you can appreciate there's kind of different shades of real world as well. I think I would conceptually think about the entire spectrum. On one hand, you will have even clinical trials, restrictive clinical trials, phase one, phase two, where really the healthiest of the healthiest patients can participate, and a lot of people who wanted to participate cannot because they are not eligible by the inclusion exclusion criteria. And then moving beyond that, there will be the phase three randomized control trial, which is still somewhat restrictive, and I think we can appreciate not a lot of people actually on RCTs for various reasons, and one of the reasons is the eligibility criteria. And then there may be the phase four trial, still a trial, but then it's more in the real world space, and it may include people in different centers and often maybe in centers of excellence, just because those tend to be the centers that conduct trials. And then beyond trials, then you may have patients. Their data is collected in different centers, and in those cases, it may be a situation where people will have to sign a consent form to contribute their data based on the research ethics board's requirement. And in those cases, we may not have every patient who received the drug that would actually be in those studies, just because every time when patients have to go through the consent process based on the design of the trial, based on many literature, we know that that's still a selected group of patients. They tend to do better by virtue of the fact that they can either consent or they are willing to consent. And then there's another scenario where maybe it's a type of study where you don't need to obtain consent and you take all patients, but they tend to occur in centers where people are doing research, so it tends to be in centers of excellence, so to speak. So, for example, if I take all the patients from my center, I come from Sunnybrook ODAC Cancer Center from Toronto. So, if I take all patients from my centers for a specific cancer type, it will be representative of the patients that we see at Sunnybrook, but would that always be representative to everyone in the rest of the country, which is not as clear. And then finally, you have the ultimate population-based analysis using administrative data, including 100% of all patients that receive the drug and link up to the various databases to do analysis. And I guess you can say that that's very highly generalizable, and because that's the entire population. That's really the entire experience of all our patients. Sometimes the potential challenge with that is with population-based analysis and the data elements, there may be some clinical elements that may not be as available in the details that we would like it to be. So I hope that I provide some shades of real world. I don't know if there's one real world that's more true to other real worlds in terms of the data, but it probably depends a bit about what's the question we're trying to ask and what's the perspective we're trying to ask that question from. If it's a clinical question, maybe all we want to know is whether the answer is a yes or no, and we're just trying to test it in a situation where we can easily collect patients from a few institutions, and we are not as interested in whether it's a yes by 5 months or a yes by 3 months improvement. If that, then maybe that will be the approach you take, and that may be the situation where the nice detail of the clinical data will be really important. Whereas if the question is real world value for money, how much the government spending and how much benefit patients are getting because of that investment, then it may make more sense to consider using all the patients that the payer is paying for, so that there's no biases of selecting some subgroup that may do differently than others, so that we know the entire picture from a payer's perspective, and knowing not just a yes/no question, but how much benefit versus how much extra money that we have to spend. So I hope that provides some answer, even though there's not a straightforward answer about what real world is real world.
Yeah, thank you, Kelvin. I know it's a pretty loaded question. I think that was a good answer. The next question was actually answered by one of your last slides in your presentation, so I'm going to hop over that one. But there's a good one here. How does the CanREValue project fit with other ongoing real-world evidence initiatives by CADF, Health Canada, and the provinces?
That's a great question. So we're all working and collaborating with each other. I would say that one of the potential interesting perspective about the CanREValue collaboration is it does have individual members from all the different important organizations and stakeholder groups. And at the same time, we have laid out an iterative process, and we are thinking about how decision makers and payers are going to be using real world data. So I think the benefit of thinking about CanREValue is that it's not necessarily better or worse, and it's not really a replacement of any other initiative. In fact, I think we're all talking to each other, and we're trying to figure out which component will be best addressed by which of the initiatives. And from a if we want to think about, part of the objective is to help payers make better decisions so that it benefits patients more, then I think having some of the payers' participation is also important. So I think CanREValue can also be helpful from that dimension as well. So I think long and short is that it's not really duplicate framework or initiative. I think they address potentially different aspects of the entire paradigm. If we think about life cycle reassessment, admittedly, I think that the CanREValue collaboration probably sits closer to the post-marketing space and not as much as the pre-marketing space. And I would imagine that Health Canada probably sit more in the pre-marketing space, but also obviously if it's an NOCC, they also have some interest in the post-marketing space as well. I hope that answers that question.
I think so, yes. We're just at our end time here, but let's go through another question or two. We have quite a few questions here, and I'd like to address as many as possible. Great. If that's all right with you, we'll do one or two more. Mm-hmm. So our next one here is, how and when can industry participate to provide input on the framework from CanREValue?
Oh, that's a great question. to some degree, through the quality of interviews, some of the industry groups or some of the members from the industry groups may have already been providing some suggestions and input for that process. But importantly, as I mentioned, Dr. Bill Evans actually are currently trying to roll out his engagement working group, and some of the initial contact was with a group called JOPT, and so the conversation seemed to have went well, and the next step is I think when Bill is back, there will be further conversations as well. And so one of the things that I think we'll be doing very shortly is once we have some idea about the early development of the first draft, we'll actually hope to seek out to all the stakeholders group, but also definitely including industry to and find out how we can solicit input from them. I know that this conversation, I don't know if this may take a little bit more time, and perhaps maybe it's one of the things that we can discuss further for the person who asked the question or the group of people who asked the question, to please email us at that address to show your interest, and we'll try to get back to you. But I think Bill has a few ideas about how to move forward.
Perfect, thank you. I'll take one more question here, and then we're going to wrap up. Sorry we couldn't get to all of them today, but I think a lot of them can be addressed if you get in contact with them via the email and the PowerPoint as well. But this is a really good question. One of our attendees is interested in learning more about real-world evidence and the varieties of ways in which the information is collected. And they're wondering if you have any good primers or other resources on the subject that you can direct them to.
Primers. I think in the literature there are lots of nice summaries to allow people to understand, at least on an introductory level, about what real evidence is. However, a lot of those that I know of, obviously, it's in medical journals, literature, so I don't know if they are for regular consumptions or not. And I think over time, this may be an important issue for not just our group, but many groups to address, is we want to make sure that actually people without technical backgrounds can understand the rationale why people are looking at real-world evidence and its potential use. And we need some ways to improve transparency of what people are doing, so that they understand and can feel that the process, hopefully it's doing what's supposed to, but if not, at least they will have an opportunity to provide their thoughts. I'm not sure. I mean, certainly what we are doing here with CCSN, not to put a plug to CCSN, I think it's doing good work to encourage, webinars such as this one, but also other webinars that's related to real-world evidence, so that different speakers can discuss about real-world evidence from different perspectives and maybe a different real world each time. That certainly it's one resource that I know of. But I do admit that there are some newsletters here and there on the internet, but I'm not sure if I would be able to say there's one consistent, strong source. And I think this question identified a potential need to have that.
Yeah, certainly. Thank you. And yes, we do on at CCSN have some webinars we've done in the past, and some coming up in the future on the subject of real-world evidence. So we'll definitely keep an eye on that as well. Thank you so much,